Hello, everyone. Welcome to Chapter 6, Communication and Relationships in LPN 114 Fundamentals. So the communication process is an exchange of information, feelings, needs, and preferences between two people. A sender and receiver participate in the communication process and offer feedback. So effective communication in healthcare is particularly important for several reasons. First of all, it's essential to proper documentation. It's the foundation of nurse-patient relationships. It helps to establish proper transfer of healthcare information. And it's a key element of reporting information to other healthcare workers. There are two types of communication, verbal and nonverbal. Verbal is the conscious use of words, both spoken and written. And an example of that might be a vocalization of pain. Nonverbal communication is conveyed by body language. That can be facial expressions, posture, body positioning, gestures, touch, and appearance. So somebody might have a rigid posture, they might have brow tightening, or a manicured appearance. With face-to-face communication, it's an active process, and it's completed when the receiver offers feedback. It involves both parties sending and receiving messages simultaneously. Again, that was face-to-face communication is an active process completed when the receiver offers feedback, involves both parties sending and receiving messages simultaneously. There are many factors that affect communication. First of all, personal space. Proxemics is the word that refers to the amount of space that people need between themselves and others to feel comfortable. Body positioning can affect communication, such as slumping or folded arms. Language can affect communication because that is what conveys ideas. And then attitude affects communication. Language and nonverbal cues show this. And communication is affected by emotions as well. Language can really stir emotions, which are really powerful feelings. Emotions are divided into two meanings. The denotative meaning is the literal meaning, and the connotative meaning is the emotion that can be associated or attached to words. For example, the book uses the three words love, death, and cancer as being very emotionally charged words. And there are some words that have a positive connotation, others that have a negative connotation. An example of a positive connotation word would be courageous. And a negative connotation word might be nosy or conceited. And back to the body positioning, the book lists a couple of ways that nurses can have better body positioning when talking with a patient. And the example they use is that if a nurse stands over and peers down at a seated patient, it may be more of an authoritative type feeling by the patient, and they may not like that. So you want to try to be eye level with the other person, leaning slightly forward and maintaining an open body posture. And that would indicate that you are willing and interested in learning about what their situation is. And then back to personal space as well. Your book on page 103 lists some of the space distance zones that have been identified, and they identify intimate as ranging from physical contact to 18 inches, casual personal 18 inches to 4 feet, social consultative 4 to 12 feet, and public 12 feet if possible. Active listening is a really important part of communication. It uses all the senses to interpret verbal and nonverbal messages. It demonstrates that you're interested in patients' feelings, concerns, and needs. And in order to carry out active listening, you need to tune out all distractions, pay attention to what they're saying and not saying, sharing perceptions, and responding to the patient and providing feedback. So, which of the following terms refers to words that can elicit emotional responses, resulting in a message that is distorted or altered? And that answer is C, connotative meaning. Words such as love, death, and cancer are emotionally charged. They can elicit specific emotional responses that distract the listener because of past experiences, resulting in a message that is actually distorted or altered. There's different styles of communication. The first one is passive or avoidant. It's when a person has a desire to avoid confrontation and they don't have the ability to share feelings or needs with others. Aggressive style of communication is putting one's own needs, rights, and feelings before those of others. So an example of that might be somebody charging into the emergency room wanting to be seen first. Maybe they're belligerent and wanting to be seen ahead of the others. And then an assertive style of communication involves standing up for oneself without violating the rights of others. Your book talks about a communication method that's abbreviated DESC. That's on page 105 in your book, but it stands for describe the behavior, explain the impact of the behavior, state the desired outcome, and consequences should grab the person's attention. So, for example, you might need to say something like, I'll need to meet with your supervisor to resolve this. Something along those lines to catch someone's attention. There are many types of therapeutic communication techniques. This is referring to patient-centered communication or therapeutic communication techniques. One way you can do that is providing general leads that will encourage elaboration with your patient. Using silence, meaning you can pause while they're talking so you can let them know that you're thinking about it and taking in all the information that they're saying. Another therapeutic communication technique is offering self. And that means saying something like, what can I do to help, to your patient? Open-ended questions, saying, tell me more about, and asking them about their situation. Restatement is just validating what the patient is saying. You could restate what they're saying in different words so that they know you're understanding what they're saying. And then seeking clarification is just saying, are you saying you feel this way? Giving information. Maybe you're giving information to a patient saying, you'll need to report to this room at this time for that test. Reflection is referring to mirroring the client's words. So, for example, if they say, I can't wait to get done with my treatments, you can say, you can't wait to get done with your treatments. And then looking at alternatives is just helping the patient to explore options as far as what they can do with their health care. And summarizing is summing up important points. But these are all listed on page 106 in your textbook, and these are really important when you're communicating with any patients. They're very good techniques to use, and many of you have probably already had experiences with them, but they're really important to exercise when you're talking with patients. In contrast, there are a lot of barriers to communication. And one of those barriers is asking questions that can be answered with a yes or no response. You won't get very far with gathering information if you ask just yes, no questions. Giving false reassurance. If you have a patient in your care who has terminal cancer, you don't want to say, oh, I'm sure you're going to get better, and try to make them feel better. You have to be realistic with them. Asking too many personal questions is a real barrier to therapeutic communication. You don't want to ask your patient, what happened between you and your husband, or you and your neighbor? Giving advice. People don't like to take advice unless they ask for it. That can be a barrier to therapeutic communication. Next is belittling a patient's feelings. That can be a barrier to therapeutic communication. You don't want to say, oh, Mrs. Smith down the hall is on her call light all the time. That's a barrier to therapeutic communication, because the patient thinks, well, if she's talking about somebody else that way, she might be talking about me that way. And that will hinder them from communicating with their nurse. And then expressing disapproval. We can't convey any biases to any type of person. And we have to keep our personal values and opinions out of caring for a patient. So in other words, we don't want to say something like, well, I don't approve of those type of people. That's just not appropriate for us to say. Then communication in crisis is really important. Things can happen suddenly without warning, and that kind of communication is really important to convey a message. And one method of communication or communication tool that can be utilized in a time of crisis is called ISBAR. And that stands for Introduction, Situation, Background, Assessment, Recommendation, and Read Back. And that is listed on page 107 in your textbook. And the example they use, I'll just read it here. Using ISBAR, you'll give the doctor a clear picture of the situation using concise explanations. And in this example, a patient has been accidentally given the wrong medication, and the nurse is contacting the doctor. So the introduction is, Dr. Jacob, this is Sharon Smith, LPN at Sunnyview Acute Care Hospital. I am calling about your patient, Alan Jones. The S, or the situation, is Mr. Alan Jones was given Mr. Alex Jones medication in error at 9 a.m. B, background. Mr. Alan Jones received 1,000 milligrams of metformin and a 100 milligram Januvia tablet, as well as an 81 milligram aspirin that were not prescribed for him. A is assessment. I did a finger stick blood sugar on Mr. Alan Jones at 9:45 a.m. when I realized the error. It was 84. I gave him a glass of orange juice to drink. He is alert, oriented, and had said he does not feel weak. His skin is warm and dry. R, recommendation. To prevent such an error from happening again, we have flagged both Mr. Alan Jones and Mr. Alex Jones medication administration records with a similar name alert, as well as adding an alert to the computer and the medication armband. Would you like us to keep checking his finger stick blood sugars? And if so, at what intervals? And then R is read back. Repeating that order, we will check his finger stick blood sugars every 4 hours until tomorrow at noon. We will report to you if his blood sugar falls below 80, and we'll give the patient 6 ounces of skim milk if his blood sugar is found to be below 80. Thank you, Dr. Jacob. So again, ISBAR is just a communication tool that can be utilized in a time of crisis where communication is really critical. There are different types of communication with the healthcare team. First of all, there's upward communication. And upward communication is the interaction with those in authority over you, and it's formal by nature. So when you're talking with your supervisor, there are some tips in talking with your supervisor. For example, you want to keep your supervisor informed. If a problem develops, make an appointment to talk it over. If you have an idea, write it down and schedule a meeting with your supervisor. Be careful which words you choose. Avoid blaming others, exaggerating, or overly dramatic expressions. Don't talk to your supervisor when you are angry, and do not respond with anger. Use I statements and explain what you are thinking. Accept feedback and learn from it. And never go above or around your supervisor. Always communicate directly with your supervisor before you go up the chain of command. And all those tips are listed on page 108, and I think they're outstanding tips to remember throughout your nursing career. And then another type of upward communication is healthcare providers' orders. And those can be written orders, or they can be over the phone. And required data for a telephone or verbal order, you will need all of the following. And this is all listed on page 109. And this is important to know too. But it's patient's first and last name, the date the order was received, the time the order was received, what needs to be done, when it should be done, an indication whether the order is a telephone order or a verbal order. And then you need to provide the following information: your name and credentials, the name of the healthcare provider giving the order, documentation that the order was read back to the prescriber for verification and validation. So you need to provide signature, credentials, the doctor's name, the date, the time, the medication dose, and the route. All of that information that we've talked about before with all of the medications, that all needs to be included in a written telephone or verbal order. And then downward communication techniques refer to speaking with people who you provide direction to or supervise. So, for example, nurses might supervise other licensed personnel, or they might supervise CNAs. And when you're communicating with people like that, it might be through job instruction, job rationale, practices and procedures, feedback, or role modeling. And these are on page 110 in your textbook. But job instruction is referring to what to do or how to do it. Job rationale, explaining why or how one task relates to another. Practices and procedures, information about what needs to be done, how it needs to be done according to policy and possible benefits. Feedback is information about how effectively a person is performing and outcomes, or verification of instruction before a task is initiated. Okay, and then as well as during or after the completion of the task. And then role modeling is communicating in a way that demonstrates to the assistive personnel how to interact effectively and appropriately with regard to the need and care of patients. And when you're practicing downward communication techniques, You want to always keep in mind that the people you're supervising have a need for satisfaction and self-esteem. And I think we can probably all relate to how it feels when your supervisor is talking to you. And it always needs to be done with respect and keeping in mind their self-esteem and job satisfaction. Then another type of communication with the healthcare team is shift report. So shift report always has to be confidential, and it has to include some appropriate data, and that includes basic patient data, special safety issues, for example, if they're confused um, or if they have an inability to communicate, sensory deficits, like if they're hard of hearing, blind, deaf, if they use any assistive equipment like a hearing aid, cane, or walker, if they have any scheduled procedures like lab tests or x-rays, or if they're scheduled for surgery, any pertinent diagnostic results, normal and abnormal results. I mentioned the assistive equipment already, and then also prosthetic devices, such as maybe they might have a prosthetic arm, prosthetic eye. All of those things must be included in the shift report. And there's actually a really nice table in your book on page 111, table 6.1, that lists all of the pertinent information that should be included in a shift report. Okay, and then communication with the healthcare team continued, referring to written communication now. First of all, know your audience. Which person or group of people who will be reading your written information. That makes a difference as far as what you write. And then also you want to be able to identify the purpose before you begin writing. That will enable you to organize your thoughts around the why of your writing. And there's a simple tip that they mention in your book, and it's an acronym, KISS, keep it short and simple. So you want to make sure your written communication is concise and factual. And then components of patient-centered communication. We always want to try to encourage and empower our patients to participate in their care. We want to be attentive. We want to be genuine, warm, empathetic, so that our patients know we really care about them. We always want to use a friendly tone of voice. No matter what's going on in our personal lives or outside the patient's room, we want to be attentive and use that friendly tone of voice all the time. And then we want to focus on the patient, not solely on the task at hand, but we want to focus on the patient, and we don't want to focus on ourselves. We don't want to come in and start talking about ourselves unless our patient wants to hear about us. We want to focus on them and see what their needs are. And this slide is referring to communication during a patient interview. There are two different types of questioning, directive and non-directive. Directive questioning utilizes closed-ended questions in order to get specific factual information. So questions that are closed-ended that we are going to use in order to get specific factual information include questions that begin with, questions that begin with who, what, when, where, how, do, and is. Okay. In contrast, non-directive questions are open-ended questions, and those type of questions are good when we want to be able to draw out the patient's thoughts and feelings. They might be good at the beginning of the interview, and it's a way for the patient to explore their thoughts and feelings through open-ended questioning. What is a characteristic of a non-directive interview? Non-directive. And that answer, of course, is that the questions are open-ended. The patient has much more input in the non-directive interview and is able to explore thoughts and feelings. Okay, and then communicating during a patient interview with nonverbal communication. Observe body language for unstated feelings or behaviors. We want to make eye contact with the patient. And we want to assess their health literacy. In other words, we want to know what knowledge base they already have about their disease process. And then we always want to avoid biases. We want to remain open and relaxed, be sensitive to people while still obtaining factual information that we need. And so we never want to be biased, in any way, but some of the big ways are race, ethnicity, and gender. And seems like now more than ever, we have a really diverse group of people in the world, and we just can't be biased in any way. And then lastly, there are some people who have special communication needs, and that will need to alter our communication when we're dealing with people who have special communication needs. Some examples are people who are deaf or hard of hearing. We would want to position ourselves in front of them so that they can read our lips. People who have speech and language impairments. Aphasia is the inability to speak or understand language. Vision impairments. We would have to make sure we identify ourselves. And one thing important with vision impairments is that we speak naturally. Sometimes we tend to think they can't hear if they can't see, but that's not true. We don't want to speak loud. We just want to speak naturally. People with mechanical ventilation or are unresponsive, it's important to keep communicating. It might be more of an informative type of communication because it's a one-way conversation, right? As opposed to being a conversational conversation. It may just be informative, but it's still important to continue that communication even if they cannot respond.